Hi, this is Terry Kuti, the founder and director of Deep Sea Journey Foundation, and also the host of the Deep Sea Journey podcast. So, thanks for joining us for an informative video that many in our community have been asking about. Today, we're going to discuss the difference between the apex flap and the DIEP flap for breast reconstruction. I'm joined by a board-certified reconstructive plastic surgeon, Dr. Oscar Ochoa, who is a member of the growing team of surgeons at PRMA in San Antonio, Texas. Dr. Ochoa's training took place in Texas. He's keenly interested in breast reconstruction clinical research, and he leads this initiative at PRMA along with his interest in lymphedema and sensory breast innervation, restoring sensation to the breast during breast reconstruction. So, Dr. Ochoa, I'm going to timestamp this interview by telling our viewers that I'm recording this in the fall of 2024. And before we begin, I just want to send out a huge congratulations to you and your team for celebrating 30 years of service to the breast cancer and breast reconstruction community. You not only serve the San Antonio area, but really you're serving patients all over the world and have become known really as one of the leading microsurgical practices across the globe. So huge congratulations goes to you for that.
Well, thank you, Terry. We are extremely fortunate to have had, the 30 years of providing breast reconstruction to patients. And huge thanks to you too, for being a voice for patients and educating patients. Breast reconstruction is a topic that nobody really learns about until they're actually dealing with it. So you providing, many patients out there with all the information is extremely important, and we really thank you for that.
Oh, well, I love doing it, especially, when I can do it with my favorite home away from home PRMA patients. And Dr. Ochoa, you were on the co-team with Dr. Crisopolo 10 years ago for me. It'll be 10 years ago in December, which I can't believe. And
Mhm.
so I like to kind of mention that because at PRMA, you guys practice the co-surgeon model. And I also want
Mhm.
listeners to know that. And so it was great having you on my team.
Mhm. Of course, my pleasure.
Yeah. Well, how about we're going to go into presentation mode here in just a bit, Dr. Ochoa, but before I do that, you tell me when you're ready for me to pull the slides up. But there's just a lot of terms when
Mhm.
we sit down and consult, or even before we come to consult, and patients start hearing things either in on different platforms or read about things, and I think some of the terms become confusing. One of them is the difference between the apex and deep. So do you want to give us just a quick little overview of what they both are, and then I'll pull those slides up so patients can actually see some of the
Mhm.
anatomical differences. So
Sure.
you,
So before we get into the nuances of the apex versus the deep flap, I want to back up just a tiny bit and begin this talk about the overall philosophy of plastic surgery, which is replacing like with like. We're trying to replace, we're trying to do a breast reconstruction and do it in such a way that results in a natural breast, natural, soft, warm, very much like the natural breast, using the abdominal tissue. Back when the abdominal tissue was started to be utilized for breast reconstruction, there wasn't a lot of knowledge about putting blood vessels together. So there was use of the skin and fat to in the abdomen to use for the breast reconstruction, but oftentimes the muscle would have to be removed as well because the muscle was carrying the blood vessels that were providing blood flow to this tissue. So the muscle itself wasn't really providing a lot of volume, but the muscle was taken with the skin and fat just as a vehicle to transfer the blood vessels with it. That was really the only function of the muscle. And as the plastic surgery community was doing more and more of these, they were we were observing that patients were complaining of issues with abdominal wall weakness because we were taking part of their rectus muscle to do their breast reconstruction. So just like everything else, that procedure evolved into lesser and lesser amounts of muscle, and then eventually we they developed the DIEP flap, which stands for the deep inferior epigastric perforator flap, which
Mhm.
basically we leave all the muscle behind and we only take the blood vessels, the fat, and the skin to do the breast reconstruction. So women ideally would retain all their abdominal core strength even after us taking that skin and fat. But we're selecting just very small blood vessels and leaving everything behind. So we're not disturbing anything that we're from the site that we're taking it from. So that is sort of the progression from very early days, very invasive, taking some of the muscle in an attempt to get good blood flow, then eventually becoming microsurgery becoming more and more readily available and familiar with it now that we're able to just take skin, fat, and blood vessels, and on some occasions also sensory nerves to regain sensation to the breast after the breast reconstruction. So that's kind of where we're at. That's
Mhm.
sort of the pinnacle of the evolution of the surgery is the DIEP flap. The DIEP flap now has a little bit of a cousin, so to speak, which is the apex flap. And then you can show your audience or your listeners some of the slides
All
to kind of get a
right.
better idea
I'm
what
going
that
to
is.
begin sharing here. I've got it. Hopefully, we'll get the first slide. Now, can you see that, Dr. Ochoa?
Yep. Sure can.
Okay. All right. Do we have the first slide up there? It's a little bit more challenging. Ah, there we go.
Yep.
Okay, let me
Yep.
start here. All right.
hmm
Okay.
So, all right. So it kind of gave a quick introduction. So we looked at the deep inferior epigastric perforator flap.
Hmm.
So the blood vessels that are providing blood flow to this lower abdominal skin and fat originate actually in the pelvis. So the way I typically describe it to patients when I'm seeing them in consultation is think of it as a tree with the tree trunk being located in the pelvis. And as the blood vessels are traveling upward, they give off branches, just like a tree
Hmm.
does. And those branches penetrate through the rectus muscle, which is the six-pack muscle, the vertical muscle that is on our abdomen. And those branches supply the skin and fatty tissue of that lower part of the abdomen. Essentially, think of it as the canopy of leaves on a tree. So those blood vessels are the branches. The canopy of leaves is the skin and fat that is being supplied by those blood vessels. During a DIEP flap, what we're doing is we're finding the largest branches of that tree that are providing blood flow to all the skin and fat that we need. And most of the time, those branches are in sort of a single file along the fibers, the lengthwise fibers of the rectus muscle. They're in single file. So we take one or maybe two that are that are between those muscle fibers. So all we need to do is essentially bring the muscle fibers or separate the muscle fibers, and the blood vessels are in line with that. And
Hmm.
there's no muscle that's actually divided. It's just basically separated as we're extracting those branches and bringing the skin and fat, the canopy with us as we are dissecting those blood vessels out.
That's a great
Sometimes,
analogy because this right here looks like the canopy. I don't know if others can see
Mhm.
my cursor, but yeah, that's a great analogy.
Right. So we're just taking the main branches. All the other small little branches that we can get rid of those. So we're basically pruning the tree. We're
Mhm.
making that tree into just a couple of large branches that are providing blood flow to the skin and fat. And in most situations, they are along the muscle fibers, so the muscle fibers just have to be separated. That is the DIEP flap. In a nutshell, that's what the DIEP flap is.
Okay.
In certain situations, those dominant branches do not align up perfectly along muscle fibers. They're actually along two separate planes of muscle fibers. So in order to take those two very necessary branches, we have to cut the muscle across to be able to take those two branches. So so using the tree analogy again. So let's pretend you have a tree with branches as we talked about, but there's these vertical, let's say it's power lines, if you will. The tree has grown through some power lines and there's some vertical wires traveling through the canopy or through the tree, basically just underneath the canopy, and you're taking two of the large branches. So all the wires between those two large branches, if you're going to be taking those two branches and the canopy above, those wires have to be cut
Hmm.
across in
Hmm.
order
Makes
to take
sense.
in order to take those two branches, which are
Mhm.
feeding the large canopy.
Yep.
So obviously, we're back at we're back in a situation where we have to cut the muscle in order to take the skin and fat and blood vessels. So are we really, creating a situation where patients can have increased pain? They can have a little bit more weakness in their muscle. So is it really something that we want to do? And the answer is no. We don't want to do that. We don't want to harm the muscle. So that's where the apex flap comes in. So in situations like that, where there's two large branches that are separated by a segment of muscle that is quite large, what we have to do is independently dissect those branches around the muscle and then disconnect them, basically cut those branches,
Hmm.
disconnect them temporarily, go ahead and leave the muscle intact. There
Hmm.
you have a great picture. Leave the muscle intact. We're able to extract the skin, fat, blood vessels, and then once we've moved it away from the muscle, now we can reattach them again.
Hmm.
And that will save those strips of muscle, those fibers, those muscle fibers that are in between those two blood vessels or those two branches, I should say, and keep that rectus muscle completely intact.
Mm.
So it saves the continuity of the muscle. It saves the function of the muscle. So it provides the patient with a much more improved chances of having or retaining all their muscle strength in their core. We have to reconnect those blood vessels again, which can sometimes be quite small and quite difficult to do, but we're able to do it the majority of the time. And it ends up being, and the patient ends up with a, a soft, warm, fully reconstructed breast with their own tissue and maintaining all their core strength.
Yeah, so really it's a replumbing technique, if you will, in
Hmm.
simplest forms. And that
Right.
way you get a robust blood supply once it's well, hopefully a robust blood supply once it's
Hmm.
transferred to the breast area.
Right. Hmm.
And then
But it's
you monitor that flap too, right?
Mhm. Right. We monitor the circulation to the tissue
Mhm.
postoperatively. One of the questions I hear sometimes patients ask is, you know, uh, do you know beforehand whether you're going to need to do an apex flap or can I have a DIEP flap?
Mhm.
And the answer is most of the time we don't know for sure until we are in the operating room and we find the exact location of those blood vessels and determine, okay, is this is this going to be best done with an apex flap, or is this something that can be done with a standard DIEP flap? And that's something that we have to make a decision intraoperatively. Sometimes with patients that have a very that, for example, need a large amount of volume for their breast reconstruction. Sometimes those patients need much more blood vessels, and an apex flap is necessary. Sometimes that volume is modest; it's not that much, and we can maintain or we can leave the configuration of the blood vessels such that it will just allow us to do a conventional DIEP flap. So it
Okay.
all depends on vessel location, volume needs. All those things have to be taken into consideration when we're making that intraoperative decision.
I'm really glad you brought that up because I have heard patients say, I'm going to ask for an apex flap, when in fact they may not even need it. And
Right.
so, yes, I think knowing the difference between these two terms, Dr. Ochoa, is very beneficial. And patients need to be aware that they may not need an apex flap. You gave a
Mhm.
wonderful description on that. Thank you so much. So, what I'm going to do for our viewers is I'm going to put information at the end of the video so that they will know how to reach you, Dr. Ochoa, if they have any further questions, or, they can put comments on the YouTube video channel itself that I will have up for them. And if I can't answer the question, I know I can reach out to you and we'll find answers for them. But I'm very, very happy today that you joined me and, shared this information with our viewers. And I also want the viewers to know that PRMA is also part of the larger, or you're a member of the ARSA network. It's a large group of surgeons, and that stands for Advanced Reconstructive Surgery Alliance, and I'll have that information also in the show notes. But thank you so much for joining me today. I just really appreciate your time, your uh, all the information that you gave us, because I know you had surgery today. So
Mhm. My
really,
pleasure, Chair.
yeah, I just really appreciate it. So thank you so much.
Sure, my pleasure, Terry. And thank you for disseminating all this information to all the patients, all the listeners. You're doing a great service by doing that. So greatly appreciate you.
Oh, well, you're very welcome. It's absolutely my pleasure. Thanks so much.
Okay, Terry. Have a good day.